Okay, and welcome to the Davies Use Case webinar being presented by St. Stephen's Hospital in Hervey Bay, Australia. On Middleware, this is a Davies award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm a manager at HIMSS on the thought leadership team, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice, guidance, access to clinical data to analyze progress, and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers from St. Stephen's, Larnie Wright. Larnie is Assistant Director of Nursing there at St. Stephen's, and we'd like to welcome her. And Larnie, you can begin your presentation when you're ready. And again, thank you for joining us today.
Okay. All right. Thank you, Arnold. My name is Larnie Wright. I am a registered nurse and currently the Assistant Director of Nursing here at St. Stephen's Hospital in Hervey Bay. We're going to talk a little bit about our middleware case study that we have fulfilled here at St. Stephen's. All right. Our problem was dealing with the whole journey of digital transformation. We wanted to improve access to all of our data and the images in a near real-time experience that would improve the efficiencies of our documentation, ultimately improve patient safety and enhance the patient experience. Some of the particular targeted areas we had was to improve all of the care team's communication with one another and the patients, to be able to identify and improve the identification of deteriorating patients, to decrease the infection rates throughout the organisation, to improve management of pressure injuries, prevent deterioration of those pressure injuries, to increase the patient engagement within our healthcare journey, and ultimately implement that scalable platform of our device connectivity. The solution was implementing this scalable system, and we utilised our middleware. So an example of some of the solutions that we involved was our nurse call solutions and our voice-operated communication devices. We've utilised both Sarah and Roland for these purposes. The clinical decision support alert. So we have our QADS, which is an adult deterioration detection scale, sepsis alerts, and automation of those alerts to identify to the clinician possible areas to focus on. Be able to have near real-time access to data. We utilise Vitals Link, which is being able to take vitals, observations, and have them directly uploaded into the system that could be accessed remotely by our doctors or other specialists outside of the area to view in near real time. To be able to access, again, similarly, the images, we use Mortara ECGs so that we can do a full 12-lead ECG and have doctors and specialists from outside the organisation view it immediately after it's been captured on the patient. To use camera capture, photographing of our wound care and being able to access it from various parts throughout the organisation, to keep them within that medical record and be able to view them from month to month, from year to year. So long-term chronic wounds, you can see the progression, whether it be deterioration or improvement of wound care as it goes on, without having to remove the wound care dressings every time you wanted to review. The medical device connectivity, so I mentioned our vitals link, our ECGs, our pumps, our monitors, our cardiac monitors. All of the devices are connected through the middleware to speak to one another and ultimately come into that electronic medical record. We also implemented our patient entertainment system. We tend to call the PES throughout the organisation. It is really the patient system. It brings together their television, their radio, a phone, internet access, educational purposes. They also have access to their diet. They can choose their menu whilst they're an inpatient in the hospital. That uses delegate and speaks to the dietitian system. It also has built-in devices that you can highlight allergies and make sure that they're not seeing things that they shouldn't be able to have, which makes an overall experience that they're not missing out. Ultimate goal to achieve is patient safety and better patient outcomes at the end of the day. So again, the connecting between our electronic room signage, our staff assignments, alerts into the electronic medical record and the voice-operated communication devices. We have single sign-on and follow me, which is a single tap-on from an ID. So we have multiple computers throughout the organisation. You simply tap on, access one computer, but you need to move from room to room. So tap off and go direct to the very next computer and tap on. There's no extra logging in, putting passwords each time. It's a save of time and it continues to follow me wherever you go through the organisation. The vital sign device connectivity, as I said, without having transcription errors and having to write down that blood pressure or temperature that you've taken, not losing information by nurses writing it on pieces of paper and having them in their pocket, being able to connect, press send, and it's automatically into the electronic medical record. Our GE monitor system integrates with our EMR in our high dependency unit and our post-care acute unit, so our recovery units. Anaesthetic machines that automatically integrate in the operating theatre. They're loading and recording just by doing what they do. Our medication management, ADC cabinets, they have patient profiling and they're linked throughout the organisation from the medical record to the cabinets throughout every computer. Single unit dose packaging, it's all done here on site at St Stephen's. We are the only facility in Australia that's been able to achieve this. All wrapped and sealed on site. We have our ECG integration using the Mortara cart. Our PACS gear for endoscopy, being able to auto-load up all of the photographs from scopes. RTLS is the real-time locating service and patient flow. So it's being able to identify where equipment is in the organisation without having to go and search and waste of time. We can also do a location of patients if they're being transferred down to radiology. You can't find your patient in your room, you can instantly check any closest computer and identify where they are in the hospital. Smart pumps, IV fluid integration. So the pumps were capturing the fluid balance chart. Nurses are not having to transcribe and transcript and being able to see from shift to shift by the pump recording that for us in the accurate time. Again, our bedside entertainment system and nurse call systems and our voice-operated communication devices using Vocera, not having to rely on leaving a room and using a phone to contact for an orderly or a porter to come and assist. You cannot have to leave the patient's bedside to access these equipment. This scalable middleware platform, this is an indication of the amount that feeds in, and all of that middleware is in the middle in the iBus system. That bus hosts and connects all of these devices into one another and feeds it into the electronic medical record. It captures and makes them speak to one another. Through using all of the Rawlins and the Cerner systems, they speak to one another and they have that device connectivity to make sure that it's making life easier for all the clinicians through the hospital and also remotely outside of the hospital. It is very open and visible no matter where you are in the organisation. At the core of everything in our digital transformation is our electronic medical record. Our middleware, device connectivity and communications, the staff assignments, all feed in through to that electronic medical record. Then using that electronic medical record, we can again use our analytics to report and capture our data that can contribute towards research, looking at our performance monitoring, our outcomes, our patient satisfaction, and being able to adopt new clinical practices based on analytics that historically using a paper-based record would be very labour-intensive and take significant amounts of time to capture the same amount of data. So how do we integrate and design the system? The middleware was very much the focus on bringing it all together, focusing on bringing the patient experience, using the clinical information, communication, and the devices. It was the hub that provided that scalable platform to allow seamless device connectivity at point of care and to drive that near real-time information that we needed. It helped support the clinical decisions that we needed to make. Care plans are built and driven by that. Our electronic room signage brings them together, that they speak to one another. You place an order into the electronic medical record, it would automatically be visible out the electronic room signage, such as infection control alerts if patients are on extra precautions because of known infection rates to protect the patients, but also to protect visitors and other clinicians coming into the room. It enhances that patient engagement to be included and to understand and have it also visible for them. Overall governance was very important. We have a vision of what we wanted the future to look like. We knew what we wanted, and then we needed to have good guiding principles to know what the rules are, to make them quite visible and workable for everyone in the organisation to achieve the outcome, to achieve the benefits, to make sure that we could measure our successes. Everything that we've designed was making sure it had a measurable capability, baseline through that principle to outcomes. So some of the guiding principles that the work redesign teams had was we would always do what is best for the patient. Patient safety continued to be our primary objective. The design principles will base what's best for UnitingCare Health as a whole. We have 4 hospitals, so we designed for St Stephen's, but we stuck with the 80-20 rule. So 80% could be used at any of our other hospitals, 20% being able to be facility specific for the intricacies and ins and outs that our hospital may have. The design was clinician driven and supported standard clinical practices from best practice and medical decision making. All of the work redesign teams were driven by multiple clinicians from various hospitals that included quality, clinical, doctors, anaesthetists, as well as analysts that would support and the design. It incorporated to make sure we met our Australian national standards, our ISO standards, our hospital licensing requirements, and of course the UnitingCare Health policies and procedures, guidelines and best practices for clinical outcomes. Being able to proactively identify, manage and resolve these issues to maintain the project timeline. We effectively utilised the resources we had to ensure design decisions were aligned with this guiding principle. Design must always be benefit driven and focused on improving performance of the organisation for a long-term future. So we created a testing domain to implement what we required, to be able to see what it looked like and being able to work with it and test whether it worked, did it meet everyone's needs. We built and designed a mock room in our former hospital and actually looked at all the different options for equipment, what worked best, what location within the room was appropriate. We had elbow-to-elbow education and support. We had the e-health team designed and working side by side just 24/7. Nurses, they know how to look after patients, but weren't as familiar with the electronic side of things, so having them work together was vital. It took time, lots of data and feedback to fine-tune to get to the system we have today. Moving from paper to a digital environment was a challenge, but it's a challenge I'd never want to go back to, facing paper electronic medical records in my career. Adoption of new workflows in a new facility is always a challenge. Change, but making sure the change management was managed in an effective and constructive way and involved all stakeholders throughout the journey. This is an example of the mock rooms that were built at our former organisation, and you can see the multiple different pieces of equipment and devices on the left-hand side, all the buzzer systems, the middleware and the devices, the pumps, the bedside screens, the workstation on wheels, which is a nurse's best friend. That is access to their patient medical record within the room at the patient bedside. The patient was always at the centre of our design, always thinking the patient outcomes was the primary focus, that the clinicians, the family, the facility and the technology was built around. And once we'd established that, that's where all of these things came on to focus on the patient experience and healing, utilising the EMR, the smart room options, the device ecosystem that was built to have security, to be evidence-based design and create throughput and efficiencies within the organisation to have mobility of that system. To ensure that our medical grade network had reliability and security of our data, it was mobile, but it engaged the connectivity to be able to access the images appropriately and stored within the system. The clinical information was always at the centre, and the clinical decision support alerts that we created pushed through our middleware that engaged the care team members based on the staff assignments. Things such as our sepsis alerts and the adult deterioration score, or the QADS as we call it, our skin risk assessments and previous prior resistant infections. Once these are entered into the system, the middleware reviews all of this information and will trigger alerts, not relying 100% on the clinicians to review this information themselves, giving the pop-up alerts and pointing them to where they need to review to make sure that it is captured in real time. The digital database can be accessed at the right time, in the right context, in the right time of that workflow. So those images and the skin protection protocols, making sure they're popping up and alerting to us at the appropriate time, make driving the care to ensure that it's streamlined and things are not always met. The patient assignment, being able to allocate particular clinicians to have a flow that if one clinician isn't able to respond to that alert within a suitable time frame, then there is a cascade system that are alert to the next care member. And within certain dedicated timeframes that we had control on being able to activate, that it would alert the nurse manager and other suitable, so it wasn't overlooked. Dashboards help us drive that, to have clear vision at any point from a manager on the unit, to visibly see all the QAD scores of every patient in the unit, to know who was the most unwell, whose vital signs were showing instability in patient care, to keep a close vision on. The capture of our real-time vitals collection improved that workflow, being able to not have to stop and transcribe, not running the risk of transcription errors, to improve the accuracy. And it's done in a timely manner and helps to support timely decision-making. You can be on a telephone with a physician who's not on site and do a next set of vitals, and they could instantly see it at their end and be able to base orders or decisions on those results. The connectivity between our databases and our vital signs, it is our middleware system that links all of these together. We have that HL7 interface engine that drives, that pushes it in and out of each system through the server, securely and safely and in near real time. This is a workflow design that shows in a paper-based world the simple process of taking a set of vitals from a patient, and you can see the multi-steps that are required. In the new system, by utilising vitals links, you can see the amount of steps that it takes out, which provides efficiencies for time for patients and the clinicians to achieve. It makes a much shorter timeline to be able to complete the task at hand, saves time at the bedside, which saves time that can be delivered to direct patient care in another important area. This This is the sepsis alerts, again, that all of those steps of that workflow can be taken out of the clinician's hands. It can be automatically driven and all of that background built into our middleware. It's doing the thinking for us. Clinicians are still very actively involved in the decision making, but it makes it quicker and it highlights, please look at this, then the clinician decisions can come into play. The Queensland Adult Detection Deterioration Score, again, meets with those national standards that were required under the Australian guidelines. In the paper-based system on the left, you see it is really about scoring and hoping that nurses can add up using those score systems to come to a demand. The automation of our system allows us not to have to worry, not to have to make the risk of running an additional mistake that could lead to patient safety being compromised. The clinical imaging capture system that we have camera capture, patient photos that can be used for wound care and dermatology review, enables the complete medical record, including all media, to be visual, to be able to date and timestamp on each of them. Once the photos are taken, they're stored in the electronic medical record and are accessible throughout time. Chronic wounds that can take months to years to heal, being able to review and see what that was like 3 months ago without having to go into a paper-based and flick through to find previous records. You can do a step-by-step review of click once, click twice to see visually how the progression has changed. Being able to review the wound after the dressing has been done and not have to take it all down, which would inhibit the wound growth and healing. As an example of the wound care, you can see these faux images in the medical record that can be labelled and dated and accessible from month to month and year to year. The reduction in hospital-acquired infections allows us to monitor infection surveillance. Patients are identified in our system and alerts that they may have a current infection. It can link an alert and be there visible for the next admission. High multi-resistant organisms that will take a long time to remove or maybe colonise in a patient. It's important to protect the patients and other patients from contamination. The pop-up alerts that are built into the system are driven through the middleware that alerts us to that infection rather than waiting for a clinician to find it maybe 2-3 days into their admission. Certainly helps reduce the hospital-acquired infections that can inadvertently happen through not being aware at an early time. It improves alerts for the cultures that are needed. You can track them in operational dashboards that clearly show patients who are on precautions through the room signage and the indicators for visitors, and there's also information available through their PES system, the interactive TV that is available for patients within their rooms. To reduce adverse outcomes in medical errors, positive patient identification, patients being barcode scanned, scanners in every room, having the closed-loop medication, that drug integration with the cabinet, individual being able to scan and verify cross-reference for any allergies or duplication of incidents of medications. There is a backup system for our downtime that ensures that we have good capability of access to the record should the system go down. There is backup upon backup of options, and ultimately, if all else fails, we have a paper-based system that allows every 2 minutes to capture any real orders current in that patient system. The interactive TV for our dietary system speaks to delegate using our middleware that identifies if patients have allergies. So it makes it invisible for them to see and choose an option that may include the items of allergies for them, protects patient safety. Or those who may be on a cardiac diet can't see the options that are not the wisest choices for them. So it never allows a patient to feel like they're missing out on choosing a dietary item. To help reduce our length of stay, many of these allow that clinical efficiency to drive patient workflow, to ensure we're reducing poor outcomes and to streamline the care, to have clear access to the vitals. The mobility and the efficiencies of the care plans that are driven and driving our workflows deliver and alert to the clinician the times of appointments, the times and dates of the care plan that needs to happen that helps meet our length of stay ideals. We have a patient flow and bed management system that again drives the electronically which beds are available, where is the bed clear to be able to move within the organisation from unit to unit. It eliminates the need for unnecessary wait time and streamlines the efficiency. Being able to track our equipment and identifying if we cannot find the camera for image capture, to be able to go to any computer and identify it at a click of a button without wasting time searching through an organisation. The patient experience, as we said, is always at the core of what we do. Having Delegate, which is the middleware integration for our dietary systems, improves patient safety. It eliminates the chance of receiving items that they're allergic to that could create a poor outcome. The patient entertainment system allows education and meal choice within their room at their fingertips, but it also allows access to health information and education, access to entertainment past those 24 hours which you're in hospital for, having radio, having internet, having a telephone. They also allow a image capture so that mirrors are at the bedside for those who can't actually leave bed. Research has classified that errors fall into one of four categories when it comes to the dietary systems, that they are given an allergy, a food that they're allergic to. They've received the wrong meal, which again could be a low sodium or gluten-free, which is against the doctor's order. Meals that can be meant for other patients and receiving a meal when medical orders say they shouldn't. They could be meal by mouth waiting for theatre, but to be able to give them a meal and be able to eat may slow down the planned operation or the test that they needed to undergo. This is an example of the patient entertainment system, the PES that we have at St Stephen's, and you can see it's clear, it's touchscreen, it's not complicated for anyone of any age or disability to be able to use. It complies with requirements for infection control practices. It helps optimise the workflows between patients and their caregivers because we can talk through the screens together. Fully interactive and allows the patients but also their families to utilise it. For those who can come ahead for their relatives, they can choose their menu items for the next week ahead of time without the patient having to be concerned of receiving food that they don't necessarily like. Their patients and their family and loved ones know them well. This is just in the room. You can see they're on an arm that can be moved up. The phone is also attached to this device as one of the options. They have access to call for the nurse from the patient entertainment system and the handset. Practical and reachable. The voice-operated communication devices we use, the Vocera, it integrates with our nurse call system so you can access and answer from anywhere in the hospital to reassure your patient before you physically are present within the room. It links in with our staff link. We also have the capacity management about the communication and the room availability, where the patient may have been transferred through to in the hospital. All integrate the EMR, each one, through our middleware. The telephone on the left is linked to the patient bedside. You can mute the tones at night, but pick that up and speak direct to the patient and reassure them that you're on your way, you're bringing that pain relief, whatever it may be the concern, without them wondering, is the nurse ever coming to see me? On the right is the enunciator panels that clearly indicate the area, the bed number, who they've called for, but also the time of how long they've called. In a busy hospital on a 32-bed ward, you can often have 4 to 5 patients who may be calling at once. In a previous system, not being able to visualise, you could answer the person who may have pressed it last without being aware and ensuring that you're getting to those patients in a timely manner. Capacity management is a history. Capacity management allows, that was a mistake, Arnold, I've just gone in brain blank there. History shows that equipment and being able to utilise equipment is low in an organisation when it can't be located. Using our capacity management, we have a heads-up information about where equipment is used, and it dramatically reduces time spent searching for equipment. It allows you quick access to that information and improves staff productivity. It also has location-based alerting for patients as well, those who may be moving through from operating theatre to radiology. If your patient's not in the room and you need them for a test, you can locate them and alert them quickly. This is an indicator for our capacity management about the transfer. The ability to visually see at any given point in time which room is now vacated, and you can see the brown on the far left where a dirty room is ready to be cleaned. It doesn't require a phone call or extra work for anyone to identify that that room's now clear, ready to be cleaned, improves efficiency, to know a green bed is now clean and ready and available for a patient to transfer into, but also those beds that are currently occupied by someone and that you can't assign for the next patient who may be coming through. An example of the real-time locating for equipment, you simply click on the list of the items that you're looking for and a ping, a red circle target will appear on the screen and identify the particular location. It can be driven all the way down to one ward, but it can be larger throughout the whole organisation as well. An example of the digital room signage that we have that identifies pertinent information at a glance. All of it is standard information that is important, but it's de-identified. It doesn't have patient names in a visual, in a public area for people to maintain privacy. Improved communication with family members and hospital staff as part of the orientation, letting people know what each of the symbols stand for. It displays the information on warnings in a real time. The lighting on the yellow panels indicates an infection control alert as well as the little symbol on the screen. It also shows that the patient is a high falls risk, so shouldn't be mobilising independently. Also, the glass with water can show to the kitchen staff that this patient is on a fluid restriction, so it's important to engage the clinicians before giving them their morning cup of tea and afternoon tea to capture that information. The room link connectivity all comes through that middleware and is centralised to the iBus. All of the information from the CareAware and that room link system comes into our iBus, pulling information from various sources, whether it be the Maya station, whether it be the EMR, whether it be the real-time locating service, all feeding through one central point in our middleware. Improving communication is central and key in our whole organisation, and that includes for the patients and their relatives. We have the peri-op tracking board that improves family communication for those who are waiting for that surgical journey, to be able to visualise and see them go into theatre, to know when they've reached the recovery unit, to see when they've moved to the ward so that they can go and visit immediately without waiting and not knowing. Patient information and education is delivered directly from our care plans. It helps drive the care available to patients and families to view and understand the expectations of the time they'll be in hospital or when things will happen with their diagnosis. The nurse call and alarm responses, again, centrally is the improved communication with patients and their families, utilising our peri-op tracking board to help keep patients engaged and aware of where their relative is in their journey, coming through the operating suite into recovery unit into the ward, to reduce the time wasted with not knowing where things are at and having to find staff and ask to communicate that journey. Using our inpatient entertainment to engage patients and families and improve the communication, to deliver information about education for both families and patients, whether it be from the patient entertainment system, from our care plans within the medical record, which are jointly done involving patients. A nurse call system and alarm response to patients allows the caregiver to speak directly using our mobile devices, reducing the time taken and the reassurance for family and patients that we're contacting in real time. The room signage that displays real-time information, all designed to improve the efficiencies between the clinicians and the patients and to reduce the inefficiencies of time taken to deliver the care that we need or the communication between each party. Keeping patients in the centre is very much the focus of our digital transformation system, utilising things such as our clinical dashboard, our room signage, the interaction patient stations, using nurse mobility with alerts and devices, the device connectivity, location awareness of people and devices, the real-time vital collection and medication administration, all filtering through our middleware process, which eliminates the time taken in near real time, improves communication, and transforms the digital environment in the healthcare system. An extension of what we did is, as we said, designed our smart room. There was not much point in having that individual one smart room. It relies on the organisation being a smart unit and a smart hospital, having the capability to alert from one area to the next to the next. If only one ward was digital, it wouldn't improve the efficiencies throughout the entire organisation. If one area couldn't speak to the other, it would need to rely on the old methods of telephone and not recording in real time. So what have been the lessons learned? What we know is it required a multidisciplinary team approach to include all of our key stakeholders to get the support and guidance of leadership, to involve everyone to make sure that in this journey we involved each and everything met each one another's workflows. Creating a testing domain allowed us to play with the functionality and meet the requirements needed for all of those key stakeholders. It allowed hands-on education in that mock room for clinicians and people to experience what it looked like and understand how to use it before we went live with the new system. To have elbow-to-elbow education and support, to not be fearful in front of a patient that we didn't know what to do next, having people guide and support you and created reassurance for patients, families, and also the clinicians themselves that they were capable and able to use this system. Being able to provide regular patient and family education, to engage them in every step of their journey, that they were very much the central point in this whole journey. The time, commitment, data and feedback loop, being able to fine-tune and tweak the system helped gain true adoption from those people who were involved. Let them drive, they know what they need and what they want, have them involved every step of the way, allow them the time and the commitment, give them that information of what they need to help make it work. Allowing additional time for adoption to occur and constant sharing of data to show improvement. It doesn't happen overnight, it does take time, but there are opportunities to continue to work on. Some areas which didn't seem as high priority to go live with all of the avenues of the equipment we have. It's huge and it's very overwhelming initially, but focus on those key points that drive patient safety at the end of the day. So what were the values that came out at the end? We've now, after many years using the system, we've really shown that our hospital has had 0% multi-resistant organism hospital-acquired transition. The accuracy of vital sign documentation has dramatically improved. There is 0 dietary adverse events resulting from allergies or poor information. Overall decrease in length of stay. Patients are coming in and the time efficiency saved allow them to receive the care and be home in an appropriate time frame. Sustained positive patient satisfaction over these times. Decreased our rate of readmissions. Decreased our overall hospital falls rate and decreased pressure injuries acquired within the hospital. All clinically be able to prove from our data analysis over this time. Our Net Provider Score, which is our patient satisfaction, we can clearly see have all driven upwards over time. We're continuing to review this month by month, and we are leading the organisation with this digital system at a 9.25 out of 10. Great patient satisfaction score. Our readmission rate within 28 days and within hours, you can see the general trend line, as opposed, we can see that slight increase from 2017 was with new implementation of standards that we are capturing. It is real, and the way we have a key quality manager at that point, and she is drilling it down to every nth degree. The falls with significant injuries is dramatically following that trend line down. Pressure injuries, hospital-acquired stage 2 and greater, again trending down since the opening of our organisation. And there, our hospital-associated Staph aureus bacteremias continue to be way below the industry benchmark. Our length of stay in general for the organisation continues to drive down, being within safe outcomes. That, combined with the reduction in readmissions, is so clinically reassuring that we're doing good care. In summary, our local problem was to improve access, data and images in near real time, improve the efficiencies of our documentation and improve patient safety, and overall to enhance the patient experience. Through the design and implementation, we focused on that electronic medical record and the scalable platform that meets the device connectivity. Using that middleware, targeted areas for improvement were communication with the care team, infection control, monitoring device data, and enhancing that patient engagement. The healthcare IT, the integration points represent that hub and spoke model where middleware is the hub and provides seamless connectivity for all of that device integration, connects the point of care within the workflow, drives our clinical decision support mechanisms and alerts. It drives our care plans. It drives the room signage that keeps the team and the facility up to date on patient risks and restrictions. It connects the right care team member to the right patient with communication needs and engages the patients in the activities throughout their journey. The values it shows is derived, we've had a decrease in infection rates that have been sustainable over the past 4 years. Our vital signs documentation improves that timing with the detection scores and the sepsis alerts. Improvements in length of stay, improvements in infection rates, reduction in falls, reduction in readmissions, and increased patient satisfaction. Our values are measurable, designed in this electronic medical system, and it's thanks to the devices that we use. All of these devices are just a snapshot of what's available, and it continues to improve and grow, and we use them better and better every day. Thank you for your time. I hope you've enjoyed and look forward to a digital world in the future. Thank you.
Well, thank you, Lornie, for joining us and sharing your Davies stories on middleware. We'd like to remind our listeners where to go find other Davies use case recordings and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Again, thank you, and thank you for listening.